Evelyn, thank you very much for that flattering introduction. So the title that I was supposed to be talking about was the one that went through the public understanding of science mill, and this was the one that apparently is very accessible. The title that I originally thought of, and I couldn't understand why they'd changed it, and then I remembered that I'd agreed to them to change it, but my preferred title was Health Inequities in the Digital Age, Beyond Neoliberal Solutions. And I'm going to come back to that neoliberal thing in a bit. But first of all, thank you to the organisers. I think it was Rachel Goodman-Hill who first invited me. Thank you to the logistics people who got me here in one piece, still smiling. Thank you, all of you, for giving up your Monday evening and engaging, as I'm sure you will, with the discussion bit. Thanks to my research team, my university, which is Oxford, my collaborators, my funders, too numerous to name individually. But I do want to just single out three people whose work I am going to be talking about and presenting. Fran Dakin, who's from anthropology, Sarah Rybczynska-Bunt, who's from sociology and based at the University of Plymouth, and Laiba Hussain from psychology. I'll tell you more about them in a bit. We've heard a lot today about interdisciplinarity, or what some people call transdisciplinarity. What I mean by that is not just collaboration across disciplines, but the active harnessing of contestation, those productive frictions when you realize that someone else is looking at a problem differently from you and they don't quite get how you're looking at it. And sometimes even the harnessing of productive conflict among disciplines. And I've spent the afternoon meeting people from the Elizabeth Blackwell Institute and also from more widely across the university. And this idea of having an interdisciplinary institute that can draw down on the expertise across faculties and be a bit of a crucible. It's a real honor to have met you all and to have heard about that institute because it's something that's very dear to my heart. So coming back to this word neoliberal, I'm not going to give you a theoretical explanation, but I thought you'd like to meet Sandra. Now, Sandra, you can see her there, is from an image bank. She comes up, if you put into one of those search engines and you want an illustration of remote or digital healthcare, and you can see that Sandra has a roof over her head, she's got a nice sofa, she's got a smartphone, she is literate. She appears to have a single, relatively non-stigmatizing condition for which she takes a single medication. And she's checking in with this health professional who might be a doctor or a nurse or a pharmacist and will no doubt take that clinician's advice. Now, Sandra is what the neoliberal policy solutions people call an activated patient. I've got nothing against Sandra. I'm Sandra, you're Sandra, you're Sandra. Everyone in this lecture theatre, with a few rare exceptions, is Sandra. And I want to spend the rest of this lecture talking about people who are not like Sandra. But before I do that, I want to talk a little bit about the changing nature of healthcare work. If you've had to have an encounter with a health professional in the last couple of years, you'll realize that things are changing. Things are changing in slightly weird ways. There's these three linked phenomena: fragmentation, when a single episode of care is spread across a large number of providers. In our data, we've got someone with a simple urinary tract infection that actually has 15 different people involved. The person who did the triage on the telephone call, the person who called the person back, the person who received the bottle of urine when the patient brought it in, the person who dipped the stick into it, et cetera, et cetera. And you can see that linked to fragmentation is taskification. Nobody manages a urinary tract infection anymore. Somebody dips the urine, someone else phones the patient back. And linked to that is deprofessionalization, which the doctors and nurses get very exercised about, when professionals' elite status, their exclusive body of knowledge, their advanced skills are undervalued and sometimes even derided. So those three things are happening. There's complexification. Now, the obvious way that healthcare is more complex is task complexity, what I've just been talking about. There's more people, there's more technologies, there's more interaction, interactions, there's more sub-processes. But there's also something called value complexity, clashes of professional norms, scope of practice. Is that my job or your job? And is that person qualified to do that? And people get really, really cross about this. And sometimes it's value complexity that can make an innovative idea hit the sand and just not work. Then there's these two related things, distanciation and disembedding. Now, these came from, I think, Anthony Giddens originally. And rather than explain those in the abstract, I'm actually going to give you an example. And it's an example related to my health condition. I haven't really got a health condition. I've got one of these preconditions. I've got thin bones because I'm one of those skinny athletes, and I have to have my bones checked once a year. Now, what used to happen is I used to go up to the bone clinic at the hospital. I'd put my hand in one of those machines, and it would measure my bone density, and then it would print out, a bit like one of those supermarket receipts, and I'd hold that bit of paper in my hand straight through to the doctor, and the doctor would give me my bone density result and say, yep, keep drinking the milk, you're doing all right. But actually, in recent years, that's all changed. What happens now when it's time to have my bones checked is I go off in the opposite direction to the hospital, to a community diagnostic clinic, put my arm in the same machine. I don't get the bit of paper anymore because the results are sent directly up to the bone clinic. And I go away and forget about it. And 2 or 3 weeks later, I get a phone call which says, your bone density result is this, keep drinking the milk. Now, that's both distanciated in the sense that my care for that episode is stretched across both time and space, but it's also disembedded. It feels hollowed out. It doesn't feel like a real consultation because it's not one. As a researcher, I've been studying the clinical consultation for 25 years. My unit of analysis has disappeared. Now, from my perspective, I'm perfectly happy with what's happening with my bone clinic, but I'm going to tell you later about patients for whom that is problematic and troubling. There's also responsibilization, when people are rendered individually responsible for tasks which previously would have been the duty of another. Many of you will be checking something at home. Maybe it's your blood sugar level, your blood pressure, and you've then got to send the stuff back. You are being responsibilized. And again, maybe you don't mind that because you're all Sandra, but I'm going to tell you about people for whom that's problematic. Now, facsimilization. This was a word that Fran Dakin came up with. It's kind of a bit like digital twins. It's the need to create a digital facsimile of the patient on the electronic record, and then what gets treated is not the patient, because the patient's not there anymore, they're at home. What gets treated, what gets analysed, what gets examined is that digital facsimile. Sorry, but I'm going to come with another example from my own bones. It's so much easier to use yourself, because then you don't have to kind of ask your auntie if you can use her and all the rest of it. So there I was at the gym. I'm often at the gym doing my weights, doing my plank, all that kind of thing. So I've got to strengthen my bones, remember? And I overdid it a bit, and I strained the front of my ribs. Got myself something called costochondritis, which is where the rib, where it joins the front bone, starts to get a bit inflamed, and it hurts, it's sore. And I've had it before, and there's a tablet I can have, which are a strong anti-inflammatory. And I needed some more of those. It's prescription only. So I thought, I'll get on to this e-consultation website. I don't know if you've ever done one of these e-consultations. So I get onto it, and I know exactly what I want. I know what tablet I want. I know it's worked before. First question on the e-consultation, do you have chest pain? Now, at the time, I had the worst chest pain I've ever had in my life. But I knew that the correct answer to that question was no, because the algorithm had been programmed to cream off the people with the red flag symptoms. If you're having a heart attack, you don't want to waste time, you want to go straight in your ambulance. So I said no, and then I filled out more and more of these questions, mostly writing not applicable in the box, because I wanted to get to the big box where I wrote what was wrong with me. And then I hit send. 45 minutes later, I get a text from my GP saying, Trish, your prescription has already been sent electronically to the pharmacy. So I went, down to the pharmacy, and within the hour, I had my medication. So that's because I was able to create a digital facsimile on my record that was plausible, that was accurate, that was persuasive, and then got me what I wanted. Not everyone can do that. So let me summarize what I've said so far. We cannot examine the digitalization of healthcare and the associated inequities without also engaging with healthcare's fragmentation, taskification, deprofessionalization, complexification, distanciation, disembedding, responsibilization, and facsimilization. That's a heck of a mouthful, isn't it? All right, time for some data. Well, it's very interesting that when you put the word data into an image bank, you get this, you get graphs and pie charts and lists of numbers. Actually, that's not the kind of data that I'm going to be giving you. I'm going to give you these little stories I've got written on my crib cards. It's called qualitative data. Let me tell you a little bit about something called the Remote by Default 2 study. Remote by Default 1 was when we all went over to Remote by Default during the early bit of the pandemic. Everything had to happen remotely so that we didn't all die of COVID. And then Remote by Default 2 was the bit where people said, well, we're remote now, we might as well stay remote. But actually, it felt a bit weird then because we weren't in the middle of the pandemic anymore. Anyway, so we got this money to have a look at what was going on. It's a big project with lots of members of the team, lots of participating GP practices, lots of patient and public involvement groups, and the National Institute for Health Research who funded it. So what was it all about? Well, we did research in 12 UK general practices, 2 in Scotland, 2 in Wales, 8 in England. And we wanted to know what's been the impact of the shift to remote and digital modalities for both triage, which is the bit where someone hears what's the problem and then says, right, you need to see the pharmacist, you need to see the nurse, you need to see this, you don't need to see anyone type thing, and also clinical care. Just a couple of definitions. What I mean by a remote encounter is when the patient and the staff member are not co-located. So an ordinary telephone call is remote, but it's not digital. A digital encounter means any encounter that's undertaken with the aid of digital technologies and through those technologies, even if you are co-located. And I'm going to give you some examples, or an example of a digital encounter that's not remote. So what did we do? As I say, we collected a mostly qualitative data set. We did observations. We hung out in the reception areas, in some consultations, in meetings, wherever they would have us, really. We interviewed staff and patients and lots of other people. We held workshops, some online, some in person, and we looked at safety incidents. And I'm going to tell you just a little bit about some of our findings. The current context for general practice care is, as many of you will know, characterized by financial austerity. They're feeling really squeezed. There's not enough money to hire the staff that are needed and do what people want to do for the patients. There's fewer GPs. There's more non-medical clinicians, not just nurses, physician associates, pharmacists, paramedics, et cetera, et cetera. And there's also a wider range of support staff. It's not just a receptionist. We found about 25 different titles of the different support staff, many of whom had newly created roles. We found a loss of in-person interaction. We found a lot of lonely clinicians and lonely managers sitting there having their lunch while looking at the screen and dealing with the kind of tasks that were coming through. And we found that general practice was seeing more patients and they had more complex patterns of illness. Now, it's worth, I'm not going to tell you too much about this, but I want to give you this as a bit of background before I tell you these stories, which are much more interesting. The 12 GP practices varied hugely in digital maturity, and I want to put the word maturity in inverted commas because it's not necessarily the case that the ones with all the tech are the most mature. We had one practice which was a digital trailblazer. It had all the kit and all the know-how. You went in there. Literally, the doctors were sitting in gaming chairs, and we got a photograph of one. They were doing almost all their consultations on smartphones, to the Sandras of this world, often by video. This was actually not very common, but we found this rather unusual trailblazer practice. This practice was based in North London. It was right near a Northern Line station, and all the patients were young professionals who'd jump on the Northern Line tube and go into their jobs in the city. And of course, it was perfect for them because then they could have their medical consultation in their tea break or whatever. So that was a digital trailblazer practice. We had a couple of practices that we described as digitally strategic. They have had quite a lot of digital innovations, but they were always introduced strategically with a business plan, with a pilot, with a careful assessment as to whether this was adding value both financially and for patients. They tended to be large kind of polyclinic type practices. Then there was a group in the middle that we initially had divided into two, digitally curious and digitally reactive. Curious meant that they were playing around. They said, yeah, let's try that. Let's bring that in. Maybe someone new to the practice said, well, we used to use that where I used to work. Oh, yeah, we'll give it a go, but not in a strategic way. But in addition, those practices were reacting to whatever policy must do came down from on high. You've all got to do remote triage now. So they were doing that on the back foot. But they were doing their best, and they were quite interesting practices to study. Then we had practices that we described euphemistically as digitally hesitant. They really couldn't get it together. They didn't have anyone in the practice that was driving this, so they had problems with their leadership. If those academics among you, we have this term called absorptive capacity, and what that means is, have you got the physical infrastructure, the technical infrastructure, but also the people, the horizon scanning that will allow you to capture innovations and introduce them. Well, these poor practices really didn't. And then finally, we had two practices that were very interesting indeed, that we called them strategically traditional. They had the least kit out of all the practices, but they weren't struggling. They had made a strategic decision not to introduce any or hardly any digital and remote. One of them allowed the patients to telephone in, and they had some phone calls, but mostly they were serving a clientele for whom remote and digital was not so appropriate. One was on a sink estate in Glasgow, ran a methadone clinic. Many of the patients had complex lives, drug and alcohol challenges, that kind of thing. The other strategically traditional practice was out in remote Wales, in a village, serving an ex-mining community, but also farmers. They were really a very long way away. It took us 5 hours to get to that practice. They consulted in Welsh mostly, and there was a dirty great mountain between the village and the nearest the kind of phone mast, so people didn't even have mobile phones because there was no signal. So this was a really interesting practice to study. How did we get hold of that, you might ask? Because one of our medical students said her dad worked there, so we got that. But they certainly hadn't done research before, so it was kind of lucky to have these two. But again, there were really good reasons why they weren't introducing a lot of tech. Now, in every single one of these GP practices, there were patients who had access challenges. And I'm not going to read out all these well-known, well-described risk factors for having trouble. Now, it's really important to note that just being old, just being non-white, just having what we call multimorbidity, which means more than a few things wrong with you, that doesn't necessarily mean you're going to have problems accessing care. But these things stack up. Once you've got several of these, and that's what the word intersectionality means, the multiple disadvantages. I would say that one down in the bottom right, I have got to say that I did spend 20 minutes talking to your undergraduate students and their protests today, and apparently some of them have got poor housing too. So I hope you can do something about that, Evelyn. I know you will. All right. I am going to now tell you about 3 patients with intersecting disadvantage. And these are composite cases. And the academics among you can ask me how we generate these vignettes, but we basically get some data and then we write a new story, which doesn't actually relate to any specific person, but it kind of pulls together some of the key themes. Okay, so we're going to hear about George, we're going to hear about Amir, we're going to hear about Selma. Now, George is 59. He's got mild learning difficulties. He just about manages to live alone. He's also taking tablets which give him immunosuppression for some other condition that he's got. So it means he's vulnerable to get infections. And one day, George didn't feel very well. So after a few days, he phoned up his GP's surgery, but because he's got a stammer, he couldn't get the words out, and the receptionist cut in and gave what's known as general advice, which means if you're still unwell in a few days' time, call us again. 2 weeks later, George phoned up again, and this time he managed to get across that he'd got a rash. Now, the receptionist said, and listen carefully to what she said, "Do you have a smartphone, and can you take a picture of your rash?" And George said yes. He did have a smartphone, and he could take a picture of the rash. So the receptionist then said, "Okay, I'm going to text you a link. I want you to attach a picture of your rash, and then the duty doctor will look at it." But George could take a picture, but he couldn't attach a picture. Attaching it was above his cognitive pay grade. It meant he couldn't populate the digital facsimile, which the duty doctor was then going to examine and treat. 2 more weeks later, George was finally seen by GP, by which time his shingles rash had spread the whole of one side of his trunk, and the medics among you would know that that's not very good for someone who's immunosuppressed. Fran Dakin has taken that whole idea of creating the digital facsimile, and she's written this paper for Social Science and Medicine all about how access in the digital age is very much about one's ability to do what I did when I wanted the tablets for me, costochondritis. You've got to craft that persuasive facsimile. If you can't do that, you actually don't exist. Let's hear about Amir. Amir's 21. He's got ADHD, attention deficit hyperactivity disorder. That means he can't concentrate very well. He's a bit impulsive. He's been kicked out of his parents' home, and he's sleeping on his friend's sofa. His asthma inhaler has run out, so he goes off to ask for one at his friend's GP's surgery. So he walks in. So the receptionist said to him, "Hang on a minute, you can't do that anymore. You've got to go home, get online, register online, and then phone up for an appointment." So Amir says, "Look, I don't have a computer." He doesn't say, "I don't have a home." Homeless people never say that. But the receptionist says, "Oh, no problem. We've got a protocol for people like you. I've got the form here. Stay where you are, and I'm going to ask you a series of questions. I will fill out the form for you." First question, do you have chest pain? Amir is confused. He says, "Look, I have already explained my problem. I'm standing here with my empty inhaler. I need a new inhaler." The receptionist says, "Yeah, but I've got to ask you all 25 questions on this template. This is digital healthcare, but not remote." She can't just have the conversation that Amir needs to have. Amir, of course, gets angry. The questions are stupid and irrelevant. Impulsively, he storms out. So then he calms down a bit later, and he comes back in, and the practice manager comes out of her office and says, "Now look, we've got a zero tolerance policy for abusive staff, so you can't register here." Now note, Amir has the skills to use a computer. If you sat him down at a computer, he would start gaming. What he doesn't have is the ability to see that he has to keep his cool all through that list of stupid questions in order to gain access to the doctor. Do you remember at the beginning I was telling you about when I had to work through the same list of questions, and I just knew that I had to get to the end? Amir can't do that because he's not Sandra. Sarah Rybczynska-Bont has written this paper all about that. And actually, there's a whole theoretical lens from a sociologist called Margaret Archer called fractured reflexivity, which means you can't keep your shit together when they're asking you the stupid questions. It's a very scholarly paper, actually. But that's what we made Amir to kind of illustrate this slightly abstruse sociological concept. Okay, the last story I've got for you is Selma. Selma is 75. She came to the UK from Pakistan 60 years ago. She's been a homemaker, and she never learned English, or at least she never learned enough English to be confident with the doctor. After her husband died 8 years ago, she moved to live with one of her sons and his family. Selma's got diabetes, high blood pressure, mild heart failure, 3 chronic conditions. And she used to go and see her GP, who was a second-generation Pakistani woman who spoke a little bit of Punjabi, enough to kind of, get by. But then they changed things, and Selma had to go on 3 long-term conditions registers, 3 different LTC registers, that's how you do it now, and she saw a nurse at each of those, sometimes the same nurse, sometimes a different nurse, but she was okay with that, actually, because she got to know each of those nurses, and again, she was happy to go along and have whatever it was checked. She doesn't do that anymore, though, because now what happens is every 3 months, Selma gets a text in English, asking her to supply her blood pressure, her blood sugar, her weight, and fingertip oxygen readings with on these clips. Responsibilization, yeah? The practice think that Selma is fine because her son helps her. He sends back the data very promptly, very accurately, very completely. But Selma hates this. She used to go to the doctors on her own. She valued the personal relationship with the familiar GP, the nurses that she got to know. Now she has to communicate everything through her son and also through a digital platform. Nothing is private. She doesn't mind her son, doing the blood pressure bit, but she's never going to talk to him about her stress incontinence or her low mood. And also, Selma doesn't trust the system. And Laiba Hussein, who's a multilingual, now postdoc, but was my PhD student, and she went and visited people like Selma in their homes and talked to them in their mother tongue. And she got some really interesting data about the loss of agency, the loss of trust, the loss of continuity of care, and the complete disengagement with the system from people like Selma. And what Laiba did was she developed this idea of using personas, which are like taking these vignettes, taking these composite case narratives, and developing a persona, as a sort of fictionalized, slightly stylized account, and then going into GP practices and other healthcare organizations and says, okay, what are you guys going to do with your systems and your processes that will make healthcare more accessible to people like Selma, people like Amir, et cetera, et cetera. Okay, so I'm beginning to wrap up. Instead of a model of equity based on individual deficits, based on the idea that we need to activate everyone and make them like Sandra, we need to address the structural causes of inequity that are built into the system. Now, I've got a preliminary hit list of the underlying structural causes of so-called digital inequities. And this is just to get us going. I'm sure you'll have other suggestions. First off is the expectation that every patient can follow algorithms and make judgments in real time. Many of us, most people in this lecture theatre can do it. George can't, Amir can't, and Selma can't. And they never will be able to, really. There's the idea that we're going to top up their deficits. Secondly, the expectation that the patient needs to populate their own digital record. Again, many of us are happy doing that. We quite like doing that. It actually makes it easier for us. But there are some people who are never going to be able to do that. Remote-only access routes. The idea that a patient who's walked in has to be turned away to go home and log on. As I say, some of them don't have a home. Another thing on my hit list is this unconscious stereotyping of deserving types of disability. This little kid in his wheelchair is what comes up when you put disability into an image bank. You never get Amir. You never get people with hidden disabilities. You very rarely get people with mental health conditions. So we need to make sure that when we're being equitable, that we think about the full range of conditions and impairments or whatever that are going to get in the way of people accessing care. And finally, the deconstruction of the patient into fragments, each of which is managed by the cheapest person who can do a task. You can get a little bit bothered about taskification. Let me, before I finish, just tell you a little bit about what happened to our 12 practices. The digital trailblazer continued to blaze a trail. The digitally strategic practices did really well as well. They were interested in adapting their workflows and withdrawing tech. So adapting the workflow to make tech work if it can work. If it doesn't work, despite a lot of work on workflows, withdraw it. that most of the digitally curious / reactive practices actually moved into digitally strategic. Maybe that was because they were working with us and they were learning from the other practices in the sample. Maybe they were just on a learning curve, but they did pretty well, and they felt really quite pleased with what had happened when we interviewed them at the end. The digitally hesitant practices made little progress because they didn't have the preconditions, and I'm just currently writing an editorial about how those practices who do not have the preconditions for innovation need a completely different package of support. And finally, the strategically traditional practices, of course, were still digging their heels in because they were talking about human rights and equity, and they could defend continuing to see people in a walk-up way without any fancy tech. So my conclusion is, we need to stop classifying strategically traditional organizations as digital laggards. We need to reward them, we need to fund what they're doing. We need also to learn from them, because I think they've already gone through that hit list of structural barriers, and they've developed ways of overcoming them, mainly by actually offering a very traditional service. So that is the end of what I've got to say, and I think now we have, you know what to do with these QR codes. You take a picture of them and then you get to our academic papers, should you wish to.